thank everyone for joining in, the live studio audience we have here, as well as all those that will watch this in the future on the recording. But we've got a pretty big agenda to get through here, and really, being several months into this, and everyone sort of got their feet under them, or at least surviving with using Cerner. And now it's a time to try to get into how do we start thriving with Cerner, and how do we really begin optimizing and learning a lot of the things that will help us improve efficiency. So those are things we're working on and hope to cover in this CME. We have no disclosures, so we've got that covered from the financial piece of this. But without further ado, we will jump into this. We're going to start it really at kind of what's going to seem like a basic level, and just walk through some of the tips and tricks at all different levels. And then I think this will be a sort of kick off a series of these CMEs that we can really drill into more area specific things and get more targeted in some of those. But this is going to be more of a general use overview. So I still think that will be very much worth your time. Moving into this, the first piece we really want to start with is just the actual PowerChart toolbars that are at the very top of when you log in. Beyond the typical home, patient list, message center buttons that everyone's using, there are some buttons up there that are useful. Launch point is actually, if you're in the inpatient space, you can actually look at what's going on in the ED. If you're a surgeon and you're in clinic and you're, getting calls from the ED, a quick way to jump into that is to click launch point. And of course, we can't actually do that because we'll show too much health information there, but that will actually get you into see those patients that are in there, and you'll be able to click directly into their chart. So, and throughout this, if you have any questions, just kind of hold those until we get to the end of each segment, and we'll, ask for questions then. And if there's anything you write down and you want to know more about, feel free to reach out to us after this, and we can, do some one-on-one teaching, especially with some things that we really can't show completely, as I said, due to having the PHI in it. Another, button up there in the toolbar to be familiar with is the auto text sharing utility. And so Tara is actually showing you right now, there are some navigational pieces to that toolbar where if you don't see it, it may be hidden, and there are some what are called carrots, upside down triangles, that actually have a drop down menu that show you the extra buttons that are missing. So that's where auto text sharing utility exists, and we have that demonstrated here on the screen. This is a quick way if you've got a colleague who's really just using some quick text, auto text that's helpful for them, and you're noticing that, you can actually get in here and search for them as a user and pull that auto text over to you. We're not going to get into the full, details of how to do every bit of that, but Tara is demonstrating how to search quickly through there, and it's really a simple copy over to your auto text. And then she's going to pull mine up, and I've got, quite a bit in there that I share, and I've built some even for other people, and they're hidden down there, but you can see on that left-hand side all the things there, and it's a simple copy button that Tara's showing right there, and you can copy that over to your own. So. But as I said, at a later segment, we'll get into really more how do you build your own auto text. But right now, we'll just get into the copy feature. That'd be the quickest way for people to really take what others have done and start, utilizing that to improve your efficiency. Another important button up there, I think. Sure. So, yep, across that top row here, where Tara is flashing that, that's where the launch point button is. Yes, so launch point will be the ED. You can see Columbia as well as Glasgow, and so, well, once you log into that chart, then you'll have access to that patient's full chart. So then you'll be able to see the X-rays and stuff, and we're going to demonstrate as we get into actual chart, quicker ways to see X-rays and those kind of things. So, but sometimes auto text sharing is hidden, depending on what size screen you're on, and so usually there's a drop-down menu on the right over there where you'll find that. There's also some quick links on here, such as to UpToDate, which I know a lot of people use that as a reference source. So that actually there are ways to link outside of the record into just internet websites and into regular non-Cerner content. But one of the things I think would be useful for some people that if you don't prefer UpToDate, you prefer something else, you can actually create your own quick links up there, as Tara's demonstrating right now. When you on those drop-down buttons, they will actually allow you to add, and you just have to type in or copy and paste in the website URL, and then that adds to there, and Tara has created one. And as Tara's demonstrating, you have to make sure you spell it right. Yeah, go ahead. So Dr. Lessenberry's question is if you're looking for a CPT code or something. So if there's a website where you typically go to search those things, then you could actually put that website link up there. And so when you click, it'll automatically launch that website, and then you could quickly search in that to find it. So I don't know. I mean, there's multiple resources out there. I don't know the names of them off the top of my head because I usually just Google it and find it. But you could even put Google on there. You could even put Google up there if you wanted to, as one of the quick links, so you don't have to go search for that outside of Cerner. Yeah, I think we can work. We'll come back to that. We can come back to that and get that set up for you. I think we can help with that. So,
I mean, there are lots of things I can tell you the code because it's a frequent flyer for me. But there are always instances where I can't find the code and it's something I don't do with any regularity at all.
sure.
So I literally have to get the phone out. Google CPT code for this.
Yeah, and I think that's where if there's things you're having to access internet, get on the internet, get on your phone to look up, you could create links there that would get you to that website much quicker without you having to pull up your phone, go to Google, then find the website, then find the thing. I think that would speed you up. Sure. There are, sometimes you have to look at this. There's different ways to manage these rows. This screen here currently has them in 3 rows. If you wanted to see them in 2, you wanted to put them in 4, you can actually grab those, I think it's 4 vertical dots there on the left-hand side, and click and drag those rows and move those around to whichever way best suits how you want to look at it. I think another interesting feature is some people don't want to see those rows at all. So you can actually go to the task button up there in the top left and go to highlight the task button there, and then you can actually go to the full screen mode, and it gets rid of all those bars if that's in your way and you don't even want to see them. So I think those are just some simple navigation things that if you've got a laptop and you're wanting more screen space, there are some ways to gain that back. So that wraps up really the toolbars segment here. Any further questions on that before we move on? If not, we will dive into the message center. Again, this is a little bit of a recap of what we covered in full staff, but just I know with the documentation deficiency reports and those things coming out, really wanting to make sure everyone is comfortable getting to that message center, navigating the message center. The biggest piece to remember here is how to change your display so that you're making sure you see everything that may be in your deficiency report. The drop-down menu has got a list of days to get there. Maxes out at last 90, and that's for orders, or you can load all for documents. So that's one of the things that people have been having a little bit of an issue with is I've got 200 orders to sign, but I can't see them all. So one of the trick to get around seeing those orders is to actually use the 3 dots next to that display, and it will actually pop up a calendar. And then you can go back to August. I mean, I typically go back to August 1st, and then that's, take it from the beginning, and you can see everything since then. And that's where those orders are hiding. If you're seeing that on your deficiency report, and you're looking 90 days back and you can't find them. So that's one trick we've found even since sending out those deficiency reports, is that a lot of people are struggling to find all those cosign orders.
People monitoring that and helping the pitiful, or just being chastised. I'm not sure. I hope not.
If MedStaff office hasn't already been after you, then you probably have got them done. Yes, I've been helping go through stacks and find some of these people that have got some that are 120 days old, and they couldn't find them, and so we had to really dig through here and find a process for that. So Eric and Beth would be after you if you. And right now we are still in the help the pitiful mode here.
Keep helping us.
Trying to get everyone caught up, but for whatever reason, display works really well to load all for documents, but it's orders that it won't load all, and you have to go to that calendar to go back in time. So just refreshing on how to sort of navigate that inbox. You've got your messages come here, which your messages are going to be portal messages, messages from your nurses, but particularly refills. Your orders, that's from a deficiency standpoint. That's where all those orders to cosign are going to land. Your documents section is where your cosign documents, if you have a APRN or other APC that's sending you note, or a resident who's doing notes for you, that's where they go to cosign, as well as home health orders and those things in the hospital. Inpatient queries, CDI queries also go to the documents section. Moving on down, you got the reminders section, which is down in your work items area. Reminders is where outpatient clinic coding queries will be coming. Save documents category, those are documents you've started and saved and haven't completed those and signed those off, which is very important when we get later in this talk. And your anticipated documents, which is another important area from a deficiency standpoint. The HIM department is working to identify if you're missing an H&P, you're missing a clinic note, you're missing a discharge summary, ED note, whatever it be, trying to put that in your anticipated documents, because that is one reason that's important to work, is because not only does it tell you what you're missing, and it helps you be a little more proactive with getting it before you get the deficiency report paper from MedStaff office. It also helps you make sure you link to the right FIN number when you access that patient chart. So that's what we're going to demonstrate next, is really just some tricks on how to better access patient charts and make sure you avoid issues of being in the right encounter. So as Tara's showing here, clicked on anticipated documents for this document here on Canvas ZZ test. If you're clicked on this in your message center, you can actually see up in the top right corner where the name of the patient, ZZ test, Candace, is up there. So if you've got to go in there and do documentation, your best bet is going to be able to click on that name. So that should be attached to the encounter and the FIN number for which they're wanting your documentation to be done on. So rather than having to search that and gamble on picking the right one, it's a little more reliable process.
Then how do you get rid of that? I can't get rid of the notification. Get the discharge summary. The reminders, everything you want. I get it. Now I don't know how to get rid of the notification.
So those notifications are managed by HIM. So once you complete that note, when they catch up to it and bill it and code it out, they will then go back and delete it. If they don't, then let Tara or Eric or Beth in Med Staff office know, and they'll work with HIM to make sure they get that taken out. But once you complete the documentation, at least comes off your deficiencies. But obviously all these processes are new for everyone, so there will be a little bit of lag there in HIM clearing those off. But that's something that's a work list for them of all those documents. So they're going back looking for them to make sure they're getting done, so then they can make sure those are completed.
Is it possible to delete that? Because I think I've done what you said, where I completed something, then I deleted the note. And if I deleted that message, does that cause a problem for information management? No.
The other thing I noticed with the message center is you have two ways of communicating with your nurses to, let's say, notify the patient the biopsy is negative. One goes to the medical record, communicate. The other doesn't go to the medical record where it says okay next. You put a little note in there. I don't think that becomes part of the medical record.
Correct. So that's, if you want to go back to a message, that's.
You're better off using the communicate button on top.
Right. So yeah, to Dr. Sardakis' point here, it is one of the downfalls we've seen is it leads you into thinking putting things in this comment section that Tara's typing into right now actually goes somewhere. It does not. That goes nowhere other than it signs off when you hit OK and next. You can dig that out somewhere, but it's not going into anyone. It's not going to a bucket for a nurse to see or anybody in the front office. It's technically not even a part of what will be the printed medical record that you would actually have to produce, if we're trying to appeal something or deal with any.
So where's the communicate box that he's talking about?
So Tara will go back. So when you're just clicked on it and not clicked into it, you can hit that communicate. There's a drop down there that allows you to send a message, or pretty much you're always going to want to send a message. And then you can free text in there who you want to send that to.
So if I free text in your health information management, does it go to them? Or do I have to have a specific one person name?
That's a good question. I don't know if they're built in there as a group or if they're built in there as people.
Because I don't have them. I don't know their names.
I think that particular message of the conversation, you reply and go right back to that.
Okay.
Once you delete that message, they get it, because I do the same thing with some of the messages with my nurses and stuff. I'll delete it after I send it to them, and it goes away on my list, but they get it. What my concern is when the nurses send me a message out of patient, someone wants a refill, and I go to click one order, so I don't have to open up the record. Sometimes it doesn't go to the right thing. I don't know how that happens. All I want to be able to do is launch the order and not have to worry about what bin
Yeah. So there's a fix that Cerner's put in for that for in between visits. It was something we were gonna kind of get into in another one.
Go to that screen if you would, that says you need to get things done, efficiency.
Sure.
Now, so I know how to go up to the upper right, get that person's name, get into that. I'll
Correct.
check the document, see what we did, I'll dictate the discharge summary. And an orthopedic discharge is really something to behold. But when I've done that, and I'm just gonna leave that screen just like it is, you're telling me? Just leave it and somebody else will do it. Because I would think that after I dictate it, I want to say done or something that would go away.
It should automatically complete when you complete that note, because it should be looking for you to complete. With
Isn't there a box on the right lower side that says okay next? You acknowledge it, makes it go away. Like the labs.
not for this one.
And I've done what you just said. I figured I'd type in that bottom thing, done or something, but that's not really good at all.
Yeah, I mean the way it's set up, because all you can do really is refuse it if it's not yours,
Yeah.
and then that's going to go to Tara. Who, I mean, Tara could take care of it, but
What I do, I think is to try to minimize the number of clicks and jumping up to do. I like to, if I've done it, be done with it. Know that I have done it. I won't see it.
What he said over here is that when you're done with it, is to just click the refresh button up there on the right and it makes it go away.
it should once you do complete the document, you should be able to go back and refresh, and it automatically know it was looking for that type of document, especially if it's a discharge summary, because it knows what it's looking for. Yeah. Now, if that's not happening, let us know, because I know there have been some issues with that, and particularly if depending on what document it's looking for, if it doesn't find the right one. So.
He does. He does.
I learned from Mr. Fisherman.
Yeah, I'm just saying be cautious, because it works most of the time. So it's just something to watch out for. So now, getting into the actual patient chart, one thing, getting to the part of making sure when you do go in there, one thing to be, I know it's a pain to look at, but it's a bigger pain to get it wrong if you're not paying attention to what location you're in and what fin you're on, just to quickly see that you're in a location that makes sense. I find that the location is the quicker thing to see, because generally if it's in the hospital, what room number they were in, those things make sense. So if you're not, we're briefly going to cover how to change fins, because I feel like that's something that we have enough issues with it that just doing a refresher on that. So it's something you can hover over that inpatient fin up there, and when you click on it, that brings up the whole list of all fins, which is another reason why I think it's best to try to use either your patient list or your message center or your ambulatory organizer if you're in the clinic, or launch point, or if you're in the ED, to go into that patient's visit for right now. Because once you go into this list of things, the chances that you pick the wrong one go up astronomically when you've got that big list. And so that's why we discourage searching up there in that right hand free text box as much as possible, because then you're at your own devices to pick the right one. So.
So let's say the nurse is going to, patient calls in, asks for a refill on pain medication, they send you a message. There's a little box that says launch orders. So she has to decide which fit to pick.
So that is actually based upon the fin that nurse was in when they created that message. So that's very much driven by your front office nursing pool.
It's frustrating because if they take an inpatient fin or a radiology fin and I'm trying to prescribe medications, it's not going to allow me
Correct. So,
It's frustrating, because I just want to be able to launch the order and go regardless. And now I have to back out, I gotta find the right fin, and redo the whole thing. It's very frustrating when you're sitting there trying to juggle them.
so to kind of recap that, the launch, you have to be careful with the launch orders button when you're in a message, because if the message was not created on the correct fin, there's no way to change that from within that message without going back and changing the fin number. That's one of the upgrades that I hope that Cerner looks for in the future, is when you launch orders that you can change the fin on that order, because it actually comes up there and you can click on it, but it doesn't open up the fin list. So hopeful that's something they're looking at upgrading, because that you could save it from right there if you were allowed that functionality.
One minute it's using the medication from the hospital that the patient is at the outpatient surgery center, but yet their pharmacy is where they live, and it depends on which fin you're on, and it's very frustrating, especially when you're trying to prescribe narcotics.
Yeah. So that was one thing. At a future session, we're really going to delve into all of the different complexities of fins and how to mitigate some of those issues. But to your point on that one, it's very much driven by who started it, and something, trying to work with the clinic staff and practice management to make sure, I think we have the same issues in the family medicine clinic, getting better, but it's one of those, it's a learning curve. All right. So, next thing we're going to go through is sort of just a quick, overview of dark menu versus light menu and what you can do in both of those, as well as some of the, more efficient ways to utilize those. Because when you look at that dark menu and that light menu, that's a lot of different headings there to get into, a lot of different ways to look at information. The dark menu and the light menu are really essentially showing you the same information, just in a very different way. And some, there's pros and cons of each. Some have stronger points of looking at things efficiently. So we're going to move through some of those, starting with the dark menu on the far left side there. The results review is something that, looking at results, I think, is one of the more challenging things to do in the light menu, that really is tempting to have to jump back and forth between the dark menu and the light menu. In the results review, I've found, and I think Tara's recommendation as well, as using lab extended is actually a quicker way to kind of get to that. There's all those tabs there, and we're not going to go through all of them, but lab extended seems to be the quickest way to get. That takes you back about 2 years automatically. So to look back at historical stuff, it puts it in a nice way to trend that, over time. You've got some options in here of ways to actually graph and trend these values. You can click on it, any individual value, and hit the trend button if you want to see a quick list of what those trends are. You can also use these boxes on the left-hand side of the labs and check one. And when you check that, you can actually go up and and then you can actually use that to graph it if you want to see things a little more graphically inclined. So there are, there's different tabs up there. I think Path, Micro, Diagnostics are useful as well for the similar things, but actually I would prefer to look at most of those in the light menu, which we'll flip over here and show. Lab flow sheet in the light menu is a little harder to scroll through, but it has a little better functionality of quickly clicking on this like so the PCO2 there, you can click on that and quickly get a more graphic form, which then down below it actually has the chronological trend there. So that is a useful way if you're trying to look at, you want to see 20 results, it's a good way to be able to scroll right through those and see them vertically and scroll through them. So otherwise, I think looking in the diagnostics section and micro on the light menu is just good. Sure.
Is one of my staff showed me, it was really hard for me to see the results review where it was underextended. Because in the hospital, I want to try to line it up, and I have lots of things where, my results are here, and what it is all the way over here. And if you just hit recent, man, it clicks it, and then I can actually read what I've got. And it lines it up so I can see it, especially with our respiratory panels. It's hard to read what something is when it's way over to the right. And
Sure.
I just wanted to say that.
So using lab recent instead of lab extended, if you've got something that was resulted, a while ago, and there's been a bunch of results since then, you can collapse that down and see it quick.
It isn't even that there's a bunch of results since then. It's just that it's been a couple of days.
Okay.
And you're coming on to service, and someone else has done this labs, and you don't know them, and it's hard to read.
And lab recent only goes back 3 days, so there's also different ways if you go to lab extended you can actually use these tabs. There's table, group, and list. There's different ways in which you can even look at lab extended to format those results differently, just depending on how you want to look at them. And so I think that, to Dr. Hemmer's point, I believe even playing around with those buttons, maybe quicker ways to see things. If you don't like scrolling left and right, you can actually go into list mode there where it then is all vertical. And then group mode pulls them similarly so that you can, it's same data, just presented differently. So next tab we're going to go to in the dark menu is documentation. So I think one of the things that we're beginning to see now is, as we begin to put more and more documents into this system, navigating how do I find the note that I'm looking for is becoming a little more challenging. So walking through some of the pieces here, one of the important things to know about the documentation section is you can only see notes that have either been saved or signed complete. So that will play in later on when we get to how to save notes so that everyone can see, what you've got preliminarily. But as Tara's showing that display option in the documentation section, there's different options there. You've got all, and you've got all physician notes, or really the pre-built settings. What's interesting is there's an only option there, and you can use that to filter down and look for, say, only notes that you've done or a certain provider has done. I prefer using advanced filters, which we'll show in a second. If you go to all and you're using advanced filters, you can actually go in here, and this is one of these things, we're not going to get into the weeds of this, but if you want to learn more about this one, this is something to reach out to us afterward to help you come build some of these filters. I've got one built to look at inpatient only documentation. I've got one to look at op and procedure notes only. I've got one to look at messages only. One to look at clinic notes only. One to look at ED documentation only. So you can really begin to filter it and look at the things you want to look at without always having to see all that nursing documentation, plus all the provider documentation, case management, really filtering that down. So yes, you can filter anything here. Like that's documentation on the dark menu. So you can create a filter that just pulls up case management notes, just pulls up physical therapy notes. I've got one of those built too, and that's it's a quick way to move through those. And I think that's going to become more important as patients are here more and more and get 2 or 3 admissions. It's really a lot to sift through. So one last thing we wanted to show in documentation, we still have some scanned in documents. And, if anybody's had any experience looking at scanned in documents, it can be a little challenging to find those. And so how do you see it? Because it's in that small right-hand pane over there. And Tara's trying to find us a good example here. There's one. Where'd it go? So when you're on this, there are buttons. How you can just tell right there. There's very few, if anybody, is going to be able to read that. So one important button there is to find is the full screen button that can click on those scanned in documents and expand that out. And so I found that to be very useful when you're having to look at a scanned in document to be able to really see the whole thing. So then you can just hit the escape button or X out of that. But just to re-highlight that, it's a small box and has kind of a dash box around it there to take it to full screen mode. So that's an important a trick to use if you're particularly looking at scanned in records from outside facilities or anything that's had to be scanned in the clinic. There's a lot of stuff coming in from other places, physical therapy notes, home health notes, those kind of things. So, all right. So now, that was a quick overview of the dark menu and just some of the high level features that are there that I think can help speed some people up. Now getting into the light menu with some tricks in there, just starting with a quick overview of navigation of this, because to me, the light menu is where the most efficiency is to be had. So if you've got that set up the best way for you, that's how I feel like you can move through quicker. So just reviewing, in terms of your M pages and your different workflows, such as the clinic, acute, surgery workflow, those discharge, those types of things that we're working in across the top there, you can click and drag those and move those around to make sure those are in the right spot to make you, pair up the things you're clicking back and forth from if you are, especially on the inpatient side using acute and discharge. You can add and subtract from there. You can hit that X button, pull those pages out. You can hit the plus sign. There's a whole list of different things there that you might be interested in looking at and seeing what's there. But that's how you would add things back in. The one interesting thing that I think you have to pay attention to is it usually defaults to the correct workflow based on your location. So if you're in a hospital and it's taking you to a clinic workflow, I think that should be a light bulb that maybe you are not on the right FIN number that you thought you were on. So I think that's one key thing to remember is if I'm not in the right workflow, then there's probably a potential FIN issue there. So just running through that components in that light menu, that's something that's completely customizable. You can click and drag those similarly and move them in the position you want. And this is really where it begins picking up efficiency so that you're scrolling through in the order you want to scroll through for and not constantly trying to click and jump around. You can easily add and subtract components from that, and we're going to demonstrate that with the little, what they call the hamburger in the top right. And you can hover over that components, and that will give you the full list of components with the check marks next to the ones that you have selected, and the no check mark for the ones you don't. So we're going to add the opioid review and do a quick demo of that piece. That's a very important thing from a regulatory standpoint on just making sure we get those PDMP reviews. It's a very simple functionality. Everyone's probably used to this, but I just want to make sure everyone's using it to the fullest capacity. It's simple to hit the view report. Of course, we're not linked up on a real patient here, so it's not going to work, but simple to hit view report. The important thing down at the bottom that it's going to automatically check this box when you view an actual report to I certify, but making sure you hit that mark as reviewed over in the bottom right. Once you do that, then it's stamped in the record that you reviewed it. But a really neat thing about that is you can actually use, that actually creates a token in the background that we can help you create an auto text for. If you want to put that in your documentation, that signature, if it's like an auto text for your signature showing that you signed it. I do that when I refill a control med. On that message, I'll go back and quickly put in my Casper, and Tara's demonstrated that in the auto text there for you just now. How quickly you can put in an auto text that will be I've reviewed this, and then that token will put your review time in your electronic signature in there to really capture that and put it in a note, as well as it being in the background. So I think that's always a key thing, just so it's clear to anyone that looks at it when I did that. A next component we wanted to highlight on is the documents. And we talked a lot about the documentation in the dark menu, but the documents in the light menu has some similar customization in the way you can filter through it. So I don't know how much anyone's looked at that, but there are in that display section a filter there where you can filter off and on. And so one of the things is it's really actually set up for physician documentation only, and you actually have to go in, and if there's other things you want to see, you have to check the boxes for those and pull them in. I know that's something that I've looked, and that's actually specific to whatever workflow you're on. So your acute workflow filter will be different than your clinic workflow filter. So in the acute, you can put the PT notes in there. You can put the case management notes in there if you want to see those in this document section. If you're in the clinic, you can, toggle on or off whether you want to see messages or you just want to see documents. Obviously, the problem with turning more on and seeing more is then how do you get to the things you really want to see? Well, you've got the My Notes Only option. So if you're in the clinic and you've got all your messages on in there, but you really just want to see what were my last 2 or 3 notes, you can quickly click that My Notes Only button and remove everything else that isn't something that you've created and signed. Group by encounter is also a useful tool that will actually take all those documents and sort them by what encounter they're attached to. So that becomes a useful feature if you're, because many times the patients in the hospital, there may be things coming into the clinic. Now that we've got patients in both settings, there's documents coming in simultaneously on them. And you can use that group by encounter button to really organize that into what is going on right now in this inpatient, FIN encounter that I'm in, and move all that other stuff into a section by itself. So those are some things to look at and things to think about in your practice that could help you be more efficient. And those actually they're what we call a sticky feature. for the filters, and that once you change that, it will stay to whatever you've, when you click apply, to whatever it was that you set it up as, so you don't have to do that every time. Those other buttons toggle off and on. So moving to the next component, one thing that I think we've been seeing with the problem list, just to update people on that, is you also have to be careful of the sticky feature of the when you add a problem. Right now it says add as this visit, so that will remain on whatever it was you left it on. I think from looking at a lot of charts, there's a lot of people that are leaving that on probably this visit and chronic, and we're creating a whole long list of problems that are not chronic. And having admitted some of these patients to the hospital, trying to sort through there and see their 50 problems that include cough, things that URI, things that were definitely a this visit problem that needed to drop off. I think that's because people are not cognizant of whether they have this visit and chronic or just this visit clicked on there, and when they add that, aren't making sure they take off the chronic piece. So problem list management is going to be one of those important things moving forward if we don't want to bog up all that list. Yes.
If I've got a fracture, ankle fracture, wrist fracture, and that person's going to come for follow-up in 2 weeks, I've been checking chronic so the office people will know to get an x-ray of that. So when I walk in the room, it's already done, and I don't have to walk in to see them. So you don't have an x-ray, and I walk out, and I get an x-ray, and I walk back in. So I've basically seen 2 people. It's the same person. Am I doing the wrong thing to click that chronic?
You're not if you clean it up if you get it cleaned up on the end.
When?
All right, so
After the fracture.
well, I mean that's kind of when are you going to stop using that problem? That's one thing to kind of think about is when am I going to stop using it? If it's going to be you're probably going to see them a couple times in follow up from a fracture.
Say I'm going to see them for 12 weeks.
Okay. And when you get to that last visit, just make sure to there's a resolve button, and Tara's highlighting it right now. So when you get done with it, resolve that and clear it out. I think that's what you should do. I think that's the best practice there is to keep that in that chronic, because obviously they've still got that fracture for the 12 weeks you're taking care of them, but making sure we're utilizing all of our tools to clean those up when you're done, so it's not sitting there for the next 2 years.
I don't think I'm cleaning anything. There are a lot of things that I would have thought clicking that chronic button is the right thing. Scope your need. You're going to come for follow-up in a couple of weeks. Are you saying don't click chronic on that?
I think it's okay if you're going to resolve it when you're done with whatever it is. But I mean, if they've got meniscal issues, that is more of a chronic. If it's going to last more than one visit, then I think using the chronic is the right thing to do. It's just making sure you resolve it when you kind of wrapped it up.
Post-surgical things that I've been asking about.
Correct.
For that reason, you're saying go ahead and click chronic.
I think you're good to keep with chronic. So that's, I think there are some issues. Obviously, if it's a fracture, if it's something you're operating on, then that is useful. There's also ways, if it did get resolved, you can actually go down and see everything is still there. You just have to scroll down to the bottom, and there's actually a drop down you can expand and see all the resolved chronic problems. So if someone accidentally resolves it and you didn't want it resolved, you can go down there and pull those back in. There's even a previous this visit problems. So Tara's moving some down there so we can see the resolve chronic drop down. So now she resolved some of those problems, but I don't think it's going to let you do it in that same fin. But see, there's an all previous this visit problems below that. And so anything that's ever been put in as a this visit and then was a this visit only still exists in that. And so even if you did forget and didn't mark it chronic, you could then quickly go back rather than having to maybe search and type for it and put it back in. You could click down there, click it back into this visit, and be back in action without having to search for it again. Yeah, I agree. From a surgical standpoint, I think that makes most sense. Dysuria, cough, fever, shortness of breath, no.
What about, while you're right there, problem, where's that? Problem list. You know, there are two things that are linked. One is what's the problem, and the patient education. Sometimes clearly it doesn't pop up.
So are you talking about this patient education section here?
Yeah, I'm told I need to do about 4 things. I gotta get the medicines, I've gotta get the follow-up, I've gotta get a problem list, and then I've gotta get patient education.
Sure.
And sometimes I don't see the problem pop up there as the correct problem.
And so the question here is for recording that if you're in the patient education section and it's not showing up the problem that you're taking care of, are you? I mean, is it always? Are you seeing where it's marked this visit, but it's still not showing up in patient education?
The choices for the choices on patient education may not be very appropriate.
And I think I've seen that, to your point, that sometimes patient education, that whatever's in the background searching for it is not exactly linked up as it should be. And I think that's one of those things that the Cerner coding in the background.
Not a good example. Say somebody broke their tibia and I put a cast on. Well, the only thing that comes out for me sometimes on patient education is cast care or something crazy like that. Where I would rather said something about a tibia.
Right. So you can actually search, I mean, in the patient education, you can hit the more options button in the top right of that component.
And then you just.
Yeah, so up there in the top, you can hit more options, and then you can actually try to search with a little more specificity for what it is you're looking for. Right, and there's a lot of things we can do with this that we haven't even really delved into. But in the top right, you've got a drop down that can change the language. You can even begin to customize these and make them your own in some ways, and that takes a lot of work in the back end of this. But it's something, if you're interested in that, reaching out to Tara or Shandy on the Pavilion side is something I think as we get more comfortable with it, there's going to be more things that I really wanted to customize some of my education to exactly what I want it to be. And I think from a surgical standpoint, I think that's primarily more useful for the surgeons than anybody else, because you'll.
I've told different things. I've told the nursing team will put in a patient education.
On the inpatient side, nursing will do patient education unless there's something you specifically want. On the outpatient side, typically the nurses don't do that. That's more the provider's piece. Because it will print out when they do the checkout process.
Problem list, is there, can I type something in there, or must it pop up?
On that's problem list?
Yeah.
Yeah, so you've got your search bar there, and then when you start typing in that, it will start giving you all your different options as you type. And I will say one of the key tricks to searching for anything in Cerner is less is more. You're better off to type about 4 letters, hit a space, and type 2 or 3 more of whatever else is in the long problem you're looking for than to try to type an entire thing. Because the more you type, the more likely you are to misspell it. And it's just not necessary. You can probably find instead of trying to type out tibial, TIB is going to get you in the ballpark. And then you put a space and an FR, and you're probably going to find almost every tibial fracture that you want to find. And you've done that with 6 keystrokes instead of trying to type, whereas tibial would have already gotten you to 6. So, yeah.
None of them came up, 800, like that's 100. So my nurse was like, just go IBU.
IBU 800. Yeah, right. So yeah, at that point, if it's a problem, if it's a medication, if it's an order, less is more. Short bits of it, space, put in a little more bit of it, another space if you want. If it's a medicine, first 3 letters, a space, a little bit of the dose. If it's 800 milligrams you want, put in an 8, hit another space, and hit oral if it's an IV versus oral. Like that, you can with about 8 keystrokes search most things. And well, Dragon's going to at least spell it right. Well, so it's going to be okay, but you're going to want to put a space and then put more information. So you're going to want to say ibuprofen, and then 800 so that you get more information in there. But you're better off with smaller bits of information than full typed out stuff. That's just the nature of the search, and it works exceptionally well once you train yourself to search for it like you're some 16-year-old texting, and you only put in half the word. Yeah. Yeah. So another trick there is you type in whatever you want and hit enter. It will in some menus it will launch a full search piece of that. So I don't know if you want to just go to add orders and let's. So yeah, so that was one thing we didn't really have on the agenda, but we can jump into it. So when you get into adding orders, did ibuprofen. So just for an example, if you type in ibuprofen, if you're just searching, just search something and show. Just search acetaminophen. So if you're searching for Tylenol, so if you stop right here, you only are going to see ever how many that is, 12, 15, whatever the number is there. That's all you'll see. As soon as you hit the enter button, you'll get the full list out there. That's still more than anybody wants to sort through. But if you go back and did, acetaminophen, and you wanted to do, you actually want like 650, then you just, ACET 650, and now you've pretty well got that. You've already gotten down to a short enough thing. It's in your drop down without even having to hit the enter button. When you're getting into things, like I said, that are IV and PO, it's much faster to just type that oral or IV in there. And I think that's one thing that you can improve upon finding things is knowing what those tricks are. PO is not in there; it's in there as oral. So
Where do you put the PO or IV, before or after?
it doesn't matter. You can search it you can't search PO because PO is not the name. You have to always search oral. So you can actually search OR. I mean, I don't even type out oral. Like, why? Like, if you can just type in IBU space 8 space OR, you're going to get it narrowed down, boom, that fast. And I think it's one of those, it takes a little while to train yourself to search for things that way, search for it the way, but if we don't play to the strengths of the system, then we're just losing efficiency. All right, so now moving into a little more in just how to be more efficient with documentation. I think one thing that to me is a game changer is contextual view. I think most people probably already discovered this, but if you haven't, it's something we wanted to demo quickly. One issue you're going to see on a laptop is that you don't have quite as much room on here as you need to actually utilize contextual view. So you may have set everything up perfectly, but you still can't see it. So there's actually a pin and unpin option, and Tara's hovering over that. You can actually collapse these menus so that they drop over to the left. They're still there. You hover over them and find them. But when you do that, you can see how Tara's screen went from no contextual view or subjective. Her review of systems were all right there. But as soon as she dropped that dark menu over to the left, now she's turned this laptop into looking like what a desktop full screen would look like, where you've got contextual view. And I think this is one of the most important ways to be faster with your documentation, especially if you're somebody who wants to be able to review and document at the same time. If you're wanting to try to copy something you've got in an old note, quickly moving into a new note, you can see your document side by side right there with what you're already documenting on the right. It's the quickest way to transfer data, to read someone else's note, type in what the surgeon said, what the hospitalist said, and be doing your documentation simultaneously with your review.
So, let's say, there have been a couple of times where it's like, what happened to the contextual view and only got 2 columns? How do you get back to the 3 columns?
So that menu button is always going to be up there, and you hover over it, and then there's a pin in that top right corner. And so when you click on it, see how the pin goes straight up and down? That's when it's actually pinned into to stay there. When it's kind of at the angle pin, that's when it's dropped over to the side.
So like right now,
And you can actually accidentally, this actually happened over the weekend, one of the hospitalists accidentally unpinned their light menu and had never done that before. So you can unpin it as well, and it drops into that little bitty thing. And that's hard to see. That little bitty piece right there, you lose it, you may not know where it went. Luckily, I was there to bail her out.
how do I get to the 3rd column? How do you get back to the 3 columns?
To your contextual view, when you unpin the dark menu, and there, it will come back. She just unpinned that dark menu. Yep. It gives you enough horizontal space that it will pop in and out. There's 2 other ways to do this that are a little more complicated. You can go up to the navigation tab and change your zoom. If Tara's going to show it, she can show it. I wouldn't recommend it because you got to do it for every single chart. It does not stick. So it's a time waster. The other option you got is to go into the actual Windows display, which is what I did on my laptop, because I want to keep my dark menu over there. You can actually go in there, and if you want to see this, we'll show you after the fact, but you got to go into the background and actually change your display settings for what the view of the entire screen is. For those that already need reading glasses, that's going to be challenging. My time is ticking on how long I can keep doing that, because it really makes it small. But the best way is to unpin that dark menu. As I said, you can you can put, there's a lot of different things that are in the contextual view, whether that's your subjective, your objective, your assessment and plan, review of systems, procedure, EKG interpret, if you want an EKG section over there, medical decision making, hospital course. There's lots of things you can pull over there. Attending attestation is my favorite from what we have to do with supervising residents, because you can do all your documentation before that resident even sends a note to you. And I don't know if people want to use that if you're supervising in the clinic, supervising, because it's only in the clinic setting, and it may be in the ED as well. If you're supervising an APC or a resident, you can actually knock out your attending attestation before they even complete their note. And granted, you got to go back and you can go back and tweak it, but you know what you were thinking at the moment when you precepted that patient. So yes, and it's great, because that way, if it takes them, if I don't get it till I don't see it till tomorrow, well, I already had what I thought about the case documented and it's done, and then I can look at theirs and make sure it jives. All right, so next segment we want to move into is medication reconciliation. And we're just going to go till we get through this list, so bear with us. So first thing, there's two different places to access medication reconciliation, either through the home medications component or through the medications component. Just depends on what workflow you're in. Obviously the acute has both. Clinic does not. But for either one, you've got the options. So you're always going to want to make sure that med history is complete, and you've got your green check mark there. The inpatient setting, it's important to see who's actually done that down at the bottom. Waiting for the med history text to have completed that to make sure it's the best med list we can get before you do in the med rec. But doing admission med recs, inpatient and SNU are two things. The two venues where that's really getting done. All the med rec pages look very similar. Some have a little different functionality in terms of having some sort of shortcut buttons, but I think one of the important things to when you're in that is knowing that there's a tracker down here in the bottom left corner that tells you how many you got left to go. And until that grays out, you're not done. Because it's easy to get lost, and I've clicked some of these buttons, but I've missed one. Well, that tracker down there is a quick way to look, and it will actually, you can click it and it will start, it will jump you to the first one that you've left undone. So it's a quick way to say, where did I miss this? Instead of having to go down there and look for the bubble that's missing, you can hit this unreconciled orders down here, and it will jump you back up there to the one. You've also got the orange asterisk over here to the side, orange bubble with a white asterisk in it that calls out on that admission med rec what you don't have done. So there's some tricks to be more efficient with this and make sure you get it done on the first time. That way, yeah.
I've been here, and all of a sudden I get some little blue X, and I'm supposed to click the next closest medicine. And I don't sometimes, really, to be honest, I don't even know what the medicine is. They came on it. I have no idea why they're taking it. I really don't know what it's for. And I can't solve it. There's no closest match. I clicked all of those options, and I can't find anything that will help me decide what's the nearest closest medicine to that. I don't have an option of saying let the pharmacist match that.
Well, the template non-formulary may be your best option, as Tara was clicking through here. So down at the bottom, there is a non-formulary thing, and that's probably your best option if you don't see anything close in there. That actually kicks it to the pharmacy to then go review it, and they can help sort some things out.
Thanks for asking.
Now, granted, it's going to ask you, it's going to make you put in some information here, but it tells you it's this one, it's ezetimibe, simvastatin 10/20. So, it's obvious what it is. You put in the, 1, 10. I think it's one of those, you get some stuff, fill in the blanks, and the pharmacy will help you out. If they call mad at you, tell them I said it, I guess, and then they can be mad at me.
They're always nice when they call, and I'm glad they call.
Yeah.
I have no clue. I'm happy to click on for me.
Yeah, if nothing jumps out there, because usually it will recommend a match if it's a pretty clean match. But some cases, if it's giving you that, do that template non-formulary in pharmacy, that sort of flags it to pharmacy to help you out. So yeah, when you complete an admission med rec, just making sure you get your green check mark. If you get the little blue recycle arrows that I think most people call that, then you left something undone. So Tara will show you what that looks like. So yeah, you definitely want that green check mark. You don't want the little recycle arrows there. So then, the next piece is going to be your discharge med rec. I don't know that the only functionality you get there is you can bubble in some, and then you've got some shortcut buttons down there in the bottom right that will let you continue or not continue all remaining ones. I find those useful. I go down through there, I'm continuing home meds rather than having to click, 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 click. If you just are diligent about taking care of the one you're trying to continue and then hit your do not continue remaining ones, it'll fill in all those bubbles for you quickly. So you just have to watch what you're doing with that.
Question about this. It's just a perception question. So I see someone in the morning and I tell the nurses, hey, I think we're going to be able to go home at lunch. And so I want to go ahead and I want to do my discharge reconciliation before I hit craziness of office.
Explain.
And so they're on clindamycin IV. I want to take it out. So I hit the red spot. That doesn't stop it for while they're in the hospital. That just stops it for when they go home.
Correct.
Thank you.
And so, another trick to use is you can plan these instead of signing them.
Yeah, but I didn't know you could plan the med discharge.
Yes.
How do you, and then do I have to go back later and sign it?
Yes.
Oh, then yeah, I need to
That-
just go ahead and do it.
Right. Yeah, depending on where you are. Yeah.
In her instance, and she's given an option to initiate now or initiate later, what's she supposed to do? Initiate now.
So with
We're not going home until this afternoon.
right. So that's if because you're in the system all the time. When she goes to her office, she's in another system.
Right, and
It's
I can get in the system, but it's hard to manage all the phone calls and seeing patients.
Right.
And so my discharge orders, I will put initiate later. But on my
yes. So you can plan. I would plan my discharge orders in that scenario and sign your discharge med rec. I use the plan discharge med rec a lot. If it's the day before, I think they're going home tomorrow and I got a little bit of extra time, I go ahead and start queuing those things up and just plan it, and it sits there. Nobody does anything to it. It just sits there until I'm ready to sign it. And then next morning, so if we can get them out faster, I just hit the sign button. It'll prompt me for all my prescriptions I've created to sign those and send them to the pharmacy. But if I don't send them home, it just sits there. And I can go back and change it later if something changes.
This is a hard question. We've got instances where somebody's outpatient. They're going home. You go through all this stuff. You click, yeah, that's the medicine, that's the narcotic. And I click sign, and I'm gone. I'm in the car, I'm on the way to the airport, I'm getting ready to get on it. I get a phone call that says, well, they've changed their pharmacy. And can you put in a different pharmacy? No, I'm literally getting ready to step on the plane. Or their pharmacy doesn't have what you prescribe. Can you put in another medicine? I'm not even anywhere near anywhere I can put in medicine. I mean, I can't be the only guy that's happening.
Yeah, and we've got some thoughts
If you
on
can-
how to work on that and help with
there
dealing with
needs
some
to be-
messages
there needs
remotely.
to be a fallback to help. If you're truly concerned about your patient, you just screw their forearm together, and they are legit gonna hurt, and you're really trying to help. I can't tell you how many times that's happened. Now, other times I screwed it up and didn't hit the sign or something. I mean, I tried to put it in, and I'm gone then too, and I'm ready to get on the plane.
So most of those prescriptions are transferable from one pharmacy to another. So
But I think there needs to be some fallback plan where somebody can say, look, you give me the code on your phone, the 6-digit number, and we can, I'm not saying you need to make a habit of that. I'm not saying that can be used frequently, but there has to be, if you can phone in tonight and say, give that guy 6 milligrams of morphine or $2 it just seems like there needs to be some way that you can cross that obstacle and go on with your business. And you don't have to give me that answer now, but somewhere, I hope I'm describing it correctly, there's a legit problem. Either I screwed up and didn't do it properly, and the patient's now on a cellar and trying to get their medicine, or they change their mind, or grandma says they're allergic to that now. I didn't know. We didn't know. There just are instances where all of a sudden the outpatient team is calling me, asking me, can you change that and put in another medicine? And I really can't. And you could yell at me later, but I can't be the only guy that is happening.
yeah, no, I mean that is a challenge. I think that was a challenge whether it was telephoned in or handwritten because once that pharmacist's got it.
We had a button at our office and we could electronically do that medicine from the office. When I was not under this umbrella. Now that I'm under this hospital umbrella, that option is gone. So it looks like we need to think a little bit about how that can be handled.
Yeah, we'll put that on the list of things to work through. We'll get back to you.
Because we still have to call the pharmacist, right, to cancel it, you just can't cancel it here, right?
I mean, and this is me speaking out of potential ignorance here. I'm pretty sure all those prescriptions are transferable from one pharmacy to another. You just got to tell them to do it. So that's a little bit of process issue on a problem that is being made the provider's problem that could be solved by somebody else.
Yeah, I've had it.
Well, I'm not sure how true that is, but I'll find out about that too. Can't and unwilling are sometimes confused.
But it just looks like we do need some kind of rarely used fallback plan where we can truly help that person out. Legit, I know there are people that are just selling narcotics. I'm talking about the legitimate situation where you try to help them and whatever you try fail. And you're now becoming aware of it. Too late to do anything else about it. I'm nowhere near a laptop. That's just going to happen. Or after him or she's at her office. And she can't prove the Cerner system. And there's just legit reasons where there needs to be some kind of fallback. I think.
All right. Well, we'll work on that. So the next item here is the cross-encounter transfer that Dr. Thornberry was talking about at the opening. This is something very important. It's if you're sending a patient to the skilled nursing unit at TJ, this is huge. Instead of doing a discharge med rec, you actually want to be doing a cross-encounter transfer reconciliation. So that is. You won't get the green check mark for discharge. It's the only time that you're really going to go outside that. So this really helps what this does is it creates a discharge med rec, but it leaves it in almost a planned state, a future state, so that someone on another encounter can bring that and initiate it on that encounter. So that it just very cleanly takes whatever you discharge them on and allows a nurse in the skilled nursing unit to take your discharge summary and count that as the admission med rec for the SNU. Very clean, very helpful. And you can put whatever you want to. I mean, if they give it in the SNU, you can put it on there. So you have to be of course, in the correct workflow, surgery workflow, or acute workflows, because it's only on the inpatient side. There is the cross-encounter transfer, and it sits right next to your discharge. If you're in the home med section, or if you're in the medication section, it is the rightmost one there. So it's in both of those components, and you just click on that, and it looks, for all intents and purposes, looks very much like a discharge med rec. Functions like a discharge med rec. But you don't actually have to reconcile the home meds. Like, you're just choosing what to continue that you want them on when they go to the skilled nursing unit. So if you're not discharging that many patients to SNU, which, I mean, you may be discharging some patients to the SNU. Yeah. So this is really useful for you. It's useful. It's much more helpful for the patient and the SNU staff than you, but it's kind of doing our part to grease the wheels here so that patient can get their meds as soon as they get down there. And it's making sure they're getting what you wanted them on too, because you've then determined this is what I want this patient to get. And it's actually a little faster too, because you don't have to go hit all the different buttons. You get to choose to just continue or not, and you don't have to reconcile both the inpatient med and the home med, because technically they're staying on the inpatient med, but it will carry both. It will carry that on the home med list as well. So last area of reconciliation that we want to get into is actually shifting over to the clinic. So we're going to change over to a clinic patient here. The outpatient reconciliation. This is huge for MIPS. I mean, this is one thing that we're really struggling on, capturing on the outpatient side. So making sure you get this done with every clinic encounter. The key is it has to be done before midnight on the day you saw the patient. So it's not something you can do tomorrow. You can finish a note tomorrow, but if you don't get this outpatient reconciliation done, you're not going to get credit.
So what do you guys do in your workflow? That messes my workflow up.
I do it at the end. So there's, if you prescribe medicines after you do it, it can actually not give you credit because you've technically changed the medication list after you've already done the reconciliation. So there is kind of a loophole in that. So I'm typically trying to do that to the very end. Do you need any refill? Which you're probably not refilling a lot of meds, but in my workflow, it's, do you need any medication refills? And then I'm knocking it out right there at the very end.
It's just that I find myself opening and closing windows. Like, I do my note, then I gotta go back to my fee ticket. And then, I mean, it's just a pain in the neck for my flow when I do that. But I see where you're coming from, because there are times where I forget to do, or I do it before I do one more medication.
Right. And
the other question I had is, do I have to do that if the patient comes in for a lumps and bumps procedure? Or do I have to do that if I go downstairs in the women's center and do a bunch of ultrasound guided breast biopsies or stereotactic breast biopsies? Because what I usually do is I switch those visits to the clinic tab, so I don't have to go through a whole bunch of stuff. I just dictate the procedure, and that's all I do. And add the problem is, but do I have to do the outpatient medication reconciliation if the patient just coming in for a local procedure. I already saw them like a week ago, and all I wanna do is take out a lipoma, or if I wanna do a biopsy, do I have to now do an outpatient medication reconciliation?
So Dr. Sardakis' question is, if you're doing a procedure or even like a stereotactic biopsy, it sounds like, do you have to do the outpatient reconciliation? I don't know the full answer to that. I'm going to give you the answer as I think it is. If they're in the clinic, if they're in our clinic fin, you're doing an outpatient reconciliation. Or you're going to get dinged. If they're a stereotactic biopsy, they're probably registered in radiology. So you're not going to have to, I don't think you'll have to do it because only clinic fins should drive that, but I'm not the,
And the visit charge code too, that's a little bit.
and some of the visit charge code depends on it. So that's one we need to take to,
Because sometimes it pops up on the surgical workflow when they come in for procedure, and I move it to the.
you go to clinic. Yeah, so what workflow you work off of doesn't necessarily drive what's, that location and other things are driving that, not the workflow you're on. So we'll get back to you on that one because that's a good question. I never really thought about that but you all doing that. But if they come to our clinic and get a procedure done, I always do it because they're going to be in the clinic fin, and that's likely going to get.
Now, is he rewarded for the ones he does, penalized for the ones he doesn't do? And what I'm gonna get at is, so if he's had 1,000 of them, and he did this med reconciliation, before he walked in the room, and he said, oh, you need to take this antibiotic, and so he really didn't get that one right, I guess.
Potentially, yeah. That's my understanding. But I mean, you need 80-something%. So you don't, 80-something%'s the goal. 85. So you don't have to be perfect. If you're in a specialty where you're not prescribing meds every single encounter, you can probably get away with just doing it in whatever workflow there is and just seeing where your numbers go. Ann Profit just sent out all the MIPS feedback today in email, so I know where I stand.
Yeah, so I was curious because it's like, the first month you miss a few, but, I'm wondering if I'm getting dinged, not getting 100% or 95% because I've done a bunch of procedures, but I'm not doing the med rec because they're not clinic encounters, they're just coming in for procedures.
Yeah, I think that's something to take to Ann Profit and let her give us an opinion on what does that look like in the background, the way that data is being pulled. Right. So I think that's why some of these things are trying to catch people up on. So.
Yeah, we were, I don't know how far we were into it, 6 weeks maybe, and somebody said, hey, here's something else you need to do. So I'm over for everything I saw up to that point. I hope I'm better now, but I really don't know. Who'd you say sent out an email?
And Profit. Yep. She sent it. I think every single provider should have gotten it today.
Dr. Sardakis, it seems to me that if you're having a procedure done and they hold you responsible for this, that nurse, whoever is prepping them, needs to be responsible for just clicking that reconciliation and getting it done and out of the way. I mean, that's what I think needs that. Why are we saying
I agree.
that,
Nurse can't.
The nurse can't.
Nurse doesn't have the authority.
Well, I think so too, particularly in view of the fact that sometimes you're in there talking to that patient and your nurse is really waiting on you to finish with absolutely not much to do.
Right.
Why would you click that button? That seems foolish.
The nurse is allowed to do the home med collection, but not the med reconciliation.
But again, to me, that's okay, I know y'all can't change it, but to me, that's just nuts, because once again, you can call in there at 11:30 tonight, or receive that phone call about something, and they say, oh, she's got a hemoglobin of 6. Well, you need to transfuse her 2 units and check it in the morning. Or you can give a guy dilaudid. But no, you can't, you're smart enough to do all that, but you're not smart enough to click the med reconciliation button. It seems crazy. But I understand.
I just was trying to help.
I agree. That's a Cerner level functionality that we have no control over.
could argue reconciling the meds on the front end,
Right.
or, doing the med review, so I can reconcile it back.
Correct. All right, so the last thing we're going to show here is I think really important in terms of creating and saving notes. I think it's one of the pitfalls of if you're not getting in the habit of creating your note in a timely fashion, then it's leading to people losing things, having notes disappear. Then they have to then go back 2 months later, 6 weeks later when somebody finally figures out they're deficient on it. And then you don't have anything. So,
Well, the thing is, I've been noticing more and more now that the ER notes are not getting done.
that's what we're going to cover here too. And so
I mean,
that's the reasons. I've got the list of reasons why you need to do it the way we're going to show you to do it. Because if you do create your note at the time, timely, it becomes a prelim note that everyone can see. So whatever you got in there, we can at least see it. It doesn't have to be perfect, doesn't have to be pretty, but at least we can see what you've got. That's very important from the ED. So we're going to be, talking about that in their department meeting because everyone's trying to admit those patients, take care of those patients, and we need to know what's going on. Is even if you got something pulled into prelim, that can be seen. It puts it on the correct date of service because if you're doing a clinic note, at least that backdates. But if you're doing anything in the ED or the inpatient, it will drop the date of service on the time you created the note. It doesn't backdate you because the encounter is ongoing. Plus, your results are going to pull in from when you created the note. Well, if you don't create the note till 3 days later, you're going to pull in results from today, that are not where you actually saw when you saw the patient 3 days ago. Vital signs are the same way. Most recent vital signs are going to come in. So you're going to have a bunch of information in the chart that is not applicable to the patients you saw 3 days ago, and you don't want to be defending that in court of, why did your note says these things, so what were you really doing? So I think that's one thing. So that what we're talking about, especially in the clinic, making a very habit of this, and I really get on residents to be sure about this, is when you go down there and create your note in the bottom left, you can pull this up. So you can still edit this. It's a completely editable note in this section, but you just can't go back and use the components anymore. You can, but it's with great risk of what you could lose when it refreshes. So the other thing I've seen people struggle with here is you may create your note, but if you don't hit that save button down there and you leave that setting and it auto logs you out, you will lose this. You will think you did it, but it will drop this whole note out.
But if you hit sign,
So
sign on the left and submit,
it's done. Yeah.
it's done.
If you sign and submit, your signed, sealed, delivered, you're done.
Right.
But if you want to come back to it, even if you think you're going to finish it right now, I still hit the save button every time I create this note. That way I can't lose it if something happens. You get a phone call.
And I put an addendum on it.
Yeah. So that's signing, submitting, and putting an addendum is good too. But as soon as I pull this thing up, if I'm intending to finish it, I still hit the save button when I pull it up, because if I take a phone call and I get timed out and lose this, I don't want to lose the whole thing. So save, or if you've at a clinic, when I'm working through clinic, I pull this note up, I save it and close it. If I know I may not be quite done with it, I hit the save and close and move on to the next patient. But that gets that prelim out there. It drops it in my save documents so that I know I can quickly come back and finish that note. As Tara's showing, it will show up in your save documents, and that creates a nice work list for you to go back and know these are the notes you got to get finished. So that's one thing we're going to be discussing in a lot of departmental meetings, is really pressing the importance of at least saving or save and close, or just go ahead and sign it and be done with it, in order to make sure all those boxes are checked in terms of making it visible, capturing the data you want in there from a result standpoint, and getting the correct data service. You can always go back in your saved documents and modify it. Tara's showing the modify button there, which launches that right back out quickly, so you don't even have to go into the chart. You can finish it up and then add a little bit to it, pull in some auto text, whatever it is you need to do, and then sign and submit that down there, and then it's done. All right. And speaking of signing and submitting, that brings us to the end of our content we've got outlined here. Any final questions? If not, thank you all for joining. Thank you all for listening through all of this, and we'll have more to come at a later date.